So our last clip or bit that we're going to do on session 6 is going to be just a quick review. So this is the AK session 6 review. Now first we're going to go to the muscles that we covered in session 6, starting with the elbow muscles, the biceps brachii, the main elbow flexors, along with the brachioradialis and brachialis. We test the biceps brachii and the brachioradialis together. We test the triceps together, and then medial, middle, and lateral heads separately. Brachioradialis is also an important elbow flexor, as well as a forearm supinator, and in some instances pronator. We go to the wrist, the main wrist muscles that we, and it really should be called hand muscles, but the Eponins pollicis, the muscle that brings the thumb and first metacarpal towards midline. And this is a really good muscle to test for involvement of the median nerve, because it's innervated by the median nerve. The Eponins digiti minimi, which brings the fifth metacarpal towards midline, is innervated by the ulnar nerve. So with issues involving the ulnar nerve anywhere along its track, or of course the median nerve anywhere along its track, these are really good muscles to test, as well as when there's an actual hand-wrist problem. The forearm muscles, the supinator, a muscle that gets overlooked a lot with elbow problems. It's primarily a radial supinator and external rotator. It has a lot to do with maintaining the integrity of the radial humeral joint. The extensor carpi ulnaris and extensor carpi radialis, we test. We use the extensor carpi ulnaris and radialis as a group, and also emphasizing medial and lateral. It's a muscle test that we use a lot with hidden cervical disc, if you remember that, along with long head triceps or middle head triceps. Extensor or flexor carpi and ulnaris and flexor carpi radialis, very good, like lower brachial plexus test. We test it. I typically teach it with the elbow bent, the wrist flexed, where with the extensor, I like to teach it and do it with the elbow straight. Pronator teres and pronator quadratus, these are very important, especially the pronator quadratus with wrist and carpal tunnel type issues. Pronator teres as well. These are they exist only to pronate. That's their main role. Moving to the next slide here. Okay, we took the AK approach to meridian therapy further, and we found that when we find a positive pulse point and we go to a muscle related to that pulse point, that the muscle will test weak, but it doesn't strengthen to its own alarm point. And then we bring in the 24-hour clock, excuse me, and we go backward on the 24-hour clock to find the next meridian that does have, that causes a re-strengthening. And then we use the low point to bring the energy from that meridian into the next meridian downstream. I think I have a bird outside the window here. The windows are open. We also we went into the elbow, wrist, and forearm muscles. Their various conditions, like there's a condition called supinator syndrome. There's carpal tunnel syndrome, very well known, very common. You'll see it a lot. You can help these situations a lot with using AK to ferret out which muscles are involved. And then usually what we end up doing is coming back to the cervical spine. There'll be something going on midline or somewhere in the spine involving the spinal nerves. I find that most of the time I will find there's going to be some component of the problem that is cervical spine or thoracic, occasionally sometimes cranial. And then we went over the hyoid muscles, which I'm looking forward to workshopping coming up here when I get back down there. The hyoid muscles are the muscles that suspend the hyoid. They are involved in jaw opening, and they're involved in proprioception and balance, and I think also they can affect speaking and head position. And they're also often a problem with they're often a good segue into testing people for allergies, various kinds of allergies. We introduced TMJ, evaluation and treatment, and along with that, neurological tooth, how to find it, how to correct it. These are also things I'll be demonstrating. Hopefully, if I have time between now and when I come down there, I'll be able to maybe film some of these. I'm hoping to, and then we'll go over them again in the session. We also introduced the diaphragm, and the diaphragm is very important. I think probably I should have introduced it earlier in the course. Diaphragm often will show up when there's weak muscles that strengthen to breath in or breath out when you're first doing your exam. Often this is cranial. It's one of the main screens for cranial problems, but it often is diaphragm. And we talked about how to TL. We TL right under the xiphoid. And the way we correct the diaphragm is we correct problems with the psoas, the upper part of the psoas. We correct whatever we find with ribs, subluxations, fixations, thoracic and upper lumbar fixations. Usually will normalize the diaphragm as well as upper cervical problems, because the innervation, of course, is from the C3, 4, and 5. And of course, there's vagal nerve involvement too. We talked about spondylogenetic reflex. It's always kind of confusing. Spondylogenetic reflex is basically working with referral patterns up and down the spine. We talked about hiatal hernia. Hiatal hernia, along with diaphragm, hiatal hernia often is a diaphragm problem. The diaphragm problem often is related to the stomach's esophageal hiatus being irritated or stretched or somehow compromised. Iliolumbar ligament, that's where we test people in gait pattern and have them we test them in backward gait. And it's a fixation between L5 and the ilium and the sacrum, and it's corrected with strain counter strain type of adjustment, and I'll be demonstrating that too. Anyway, so at this point, just kind of a review of AK. I want to keep folding these concepts back in to the mix. AK review, tenets of AK. Muscles move bones. Muscles manage forces from within and outside the body. Nervous system is driven by afferent input. which is largely from muscles. Nervous system coordinates and sends motor signals to muscles. I mean, this is pretty basic stuff, but this is how we have to always keep going back to these basic concepts. Muscle dysfunction, either weakness or hypertonicity, is a result of improper function, improper signaling at the anterior horn of the spinal cord. That's kind of where the rubber meets the road. So whatever influences that final common pathway of motor signal is what we want to ferret out and correct. Muscles can be inhibited, weak, as a result of basically two general categories: a disruption of problems, a disruption of the components of the muscle itself at a local level. The muscle tissue is actually damaged, strained, torn, contused. There's a local problem. Or another big category is everything else. So remote issues, imbalances, injuries in the body elsewhere relating to what we categorize in the 5 factors, which ultimately result in a hyperpolarization at the anterior motor horn. And hyperpolarization, of course, means that the signal it isn't triggered. It's like the motor signal is diminished. And sometimes the muscle is affected by both. There can be, we can start out with a remote systemic cause of some kind, maybe like a subluxation, for example, in the neck. And because of prolonged suboptimal firing and force management around the shoulder, for example, say there's a subluxation C5, well, it's directly affecting the motor and sensory information traveling between the deltoid, the bicep, and over time, with normal activity, we end up injuring things because these muscles aren't showing up. We may not injure the deltoid, we might end up injuring the supraspinatus or another synergist, and then that sets into motion a kind of chronic strain-sprain situation. And ultimately we have a problem locally. But the original problem was the subluxation, which we have to trace back and find that to keep the problem from coming back. So, primary muscle weakness, we have sprain, the trilogy of strain, sprain. And this is a disruption of the proprioceptors in the muscle. And that's going to be the primary, usually a muscle that's painful and weak in the clear. And it's going to respond to spindle manipulation from center to out to strengthen and from out to in to inhibit. And it could also be the Golgi tendon organ, which is a different kind of proprioceptor that strengthens to pressing towards center and strengthens with pressing out, just the opposite. And mechanoreceptors in the periosteum, where the tendon connected to the muscle attaches to the bone. And there's a lot of mechanoreceptors in that area, and that can be disrupted from strain trauma. So those three different elements of a muscle can be compromised with an injury. Now, when we find that, we're going to also look at the antagonist, and often and usually we find there'll be disruption in the proprioception to the antagonist, a failure of inhibition. That muscle tends to be tight and fascially congested and often shortened. Now, we also find problems with the synergist to the primary muscle. And the synergist to the deltoid would be, for example, could be the supraspinatus. It could be the upper trap to some degree. It could be the upper pec. I mean, there's any muscle that shares vectors of movement with that muscle could be also put into have its proprioceptive have its proprioception disrupted. So that's a trilogy of sprain strain. Primary muscle has an injury to one of those three things, so that's a trilogy there. And then secondly, the antagonist is fascially congested. And thirdly, the synergist will usually need strain counterstrain, like a proprioceptor muscle spindle reset. The 5 factors, of course, just a quick review. We've been going over this all year, but just to keep it clear in our minds, 5 factors are going to be lymphatic congestion of the muscle, which is going to be associated with organ dysfunction. Classically, that's how we look at that. So there's going to be neurolymphatic reflexes that relate to the organ and to the associated muscle. Number 2, vascular imbalances affecting us. So, and that's where we look at the neurovascular reflexes, or what we call Bennett reflexes. Spinal nerve function itself disrupted by subluxation, fixation will cause muscle weakness, muscle dysfunction. Craniosacral function affecting the central nervous system. And there's certain cranial faults that tend to affect certain muscles. For example, the sagittal suture affects the rectus abdominalis. And of course, the sort of non-wired energy matrix of the body, i.e. the meridians, that contributes to strength or weakness, of course, of the muscle. So every muscle has a relationship to each muscle has a relationship to these 5 different factors. So here's the basic techniques. I'll hit on all of these in the review that we're going to do on the 10th of October. Of course, switching. We keep going back talking about switching. Upper and lower gait, plus IRT, injury recall technique. That's where there's basically a disruption of the way the nervous system is managing a certain part of the body based on an old injury, on old programming. Pulse points is our window into the meridians. Fixations, especially the limbic fixation, the C7T1 first rib fixation, that's a important one. But then there's all the others that cause bilateral muscle weakness. Subluxations, which are different than fixations, and we use static and or dynamic challenge to find a subluxation and to determine how we're going to correct it. So we'll go over that in detail. So I prefer dynamic challenge, but you can use static challenge as well. Dynamic challenge, you push the vertebrae in the direction you think it needs to go and let go, and there'll be a rebound weakness of a strong indicator muscle. That's a really good way to find it. Static challenge will also work if you push the vertebrae further into what appears to be its lesioned position. You'll get a weakening of a strong indicator muscle. Often we'll find a subluxation by having a weak muscle which responds to a therapy localization to that vertebral spinous or lamina, having the patient touch that area, and that weak muscle will strengthen. Then we go to a strong indicator muscle and to do our challenge. Feet. We went over feet in, I think, session 5. Feet are very important. Of course, they're the beginning of the kinetic chain. As gravity is moving us down, the earth is coming up, and the feet are the first mechanisms to manage those forces. And their ability to do that, or lack of ability, can send repercussion problems all the way up the kinetic chain. So often feet will bring back problems that we've corrected in the low back or neck if we don't correct the feet. The categories, classic, you'll see these all day long, especially 1 and 2. Category 1, 2, and 3. Category 1, of course, is a torsion of the overall spine and pelvis, and it also involves the cranium, which also typically category 1 will be associated with a temporal bulge and parietal descent pattern in the skull. Category 2 is a subluxation of the sacroiliac joint, often associated with adrenal dysfunction, sartorius gracilis weakness. The short leg will typically be on the side of PI. Long leg will be on the side of the AS. We'll go over this in the review. Category 3 is a subluxation of L5S1. And hidden cervical disc, very important, very common. You'll see these all the time if you look for them. And this is typically an anteriority of a C5, C6. That's where I most commonly see them, occasionally C4. And it'll show up as wrist weakness, especially wrist extensor weakness, and often middle head of the, or long head of the tricep weakness. Cranial fixations, we screen for them every time we find a weak muscle. We're looking for, where is it fixated, what kind of pattern. There's 3 kinds of cranial fixations. There's rotational, sutural, and flexion extension. And of course, TMJ, which we just went over in session 6. Very important. Of course, then going on down the line, diaphragm, one of the newer ones. Diaphragm, important, and stomach hiatal hernia. You will find these often now. Often it's not a true hiatal hernia. Often it is like a jamming of the stomach. The esophagus is tightened and pulled the stomach up against the diaphragm, causing diaphragm dysfunction and stomach dysfunction. And sometimes you'll find an actual hiatal hernia. The correction is basically the same. And ileocecal valve, I hope I've emphasized over the course of this course. I hope I've emphasized enough how important the ICV is. ICV is a dysfunction of the junction between the small and large intestine. It'll stick open or it'll stick closed. More commonly, I find them open. And we'll go over this in the review as well. Retrograde lymphatic, basically you tip the patient up and they go weak, and then you look at the pec minors and do a fascial flush and treat the sternum Chapman reflexes. Rocker motion, Prite, is how we go through and determine how the body modules are talking to one another. So it's a really nice way to, some AK docs like to do this right off the bat. They use this as a primary approach to their evaluation. And I can understand that. I think that's a great way to go. It really cleans up a lot of issues right away. Anyway, so basically rocker motion is dealing with the occiput C1. Prite is dealing with the upper cervicals, sacrum, and the thoracolumbar areas. And of course, meridian therapy, which we're going to talk about more in session 7. There's going to be some more information on that. And emotions, which we really haven't covered in this time around yet. I'm going to be talking about that in session 7. So we go through all these like 19 things, and then you could add more to this list, or you could glean it down. But these are all the things that will find problems, depending on what one exam leads you to, depending on the history, etc. But often the patient comes in, they have a particular complaint, and we need to clean up all these other problems if we find them before we can go in and actually treat their actual problem, whether it's a headache or digestive issues, knee problem, wherever it might be, sleep issues. Anything that they might show up with, but we have to go through and clear all these different things as we find them. So just to sum up, this is not hard, fast, carved in stone way to approach it. This is typically how I think when I'm working with a patient, especially a new patient or someone I haven't seen for a while. I check posture on every patient, every visit. Stand up, let me look at you, and I look at that. Always check for switching. Always check for if you find a weak muscle. Is it a problem with the muscle itself? Does it fit a history? If a muscle is weak in the clear, say, oh, have you done anything? Oh yeah, I forgot to say this. I was doing I overdid a bench press or something, and this pec's been bugging me. Well, right then and there, you've got a history and you've got a finding, and so you check it for spindle strengthening. You check it O&I. You check the GTOs, and a lot of times you can bring that muscle right back online, and then you check it doesn't take long once you get used to doing this. And so you're kind of working. Then you say I want to use a PMC, a pec major clavicular muscle, for my indicator muscle. I want that muscle. If that muscle is strong or weak in the clear, I want to see if I can fix it first, and then I'll use it as my indicator sometimes. Look at anything that might relate to dural torque, which of course is gait. Problems with sitting, gait plus backward gait, category 1, anything that indicates that there's dural torque that I need to address. And of course, feet. I check everybody's feet, period. Cranials, that usually I screen for right away. If there's a breath in, breath out, I go straight there and see if I can find it. I don't always fix it right off the bat. I might wait down the line. Always looking for subluxations and fixations, and meridian imbalance, and emotions. So these are things that pretty much I address on every patient, every visit. Anyway, just there's the 5-factor thing over to the right. And then you address the patient's complaint. So that is going to be the final episode of the session 6 lecture. I'm working on session 7. It isn't quite complete yet, and I'll hopefully be getting it up soon. So